Good afternoon, everyone, and welcome to our latest edition of IDSOG's Ask the Expert. We have a dream team today to talk about updates in chlamydia. I will introduce our young investigator first. This is Dr. Julia Schroeder. She's a second-year internal medicine resident in the University of Alabama at Birmingham Internal Medicine Residency Program. Julia is interested in pursuing a fellowship in reproductive infectious diseases and has recently been doing research on trichomoniasis and adverse birth outcomes. So welcome, Julia, for being here today. She will be interviewing our senior investigator, who is Dr. William Geisler. He is a professor of medicine and epidemiology in the Division of Infectious Diseases here at the University of Alabama at Birmingham. And as of this morning, he is also our newly appointed UAB STD program director. So welcome, Dr. Geisler.
Thank you.
All right, so we are going to be talking about updates in chlamydia. And I failed to mention Dr. Geisler is the lead author on the 2021 chlamydia section of the CDC's STI treatment guidelines. So we have some questions for you today.
Great.
Hey, thank you, Dr. Mosney, for the introduction, and thanks, Dr. Geisler, for taking the time to talk with us today. Let's jump right in. My first question for you is, can you talk a little bit about what are some of the major changes in the 2021 treatment guidelines?
Yeah, I would say by far the biggest change is the treatment that's recommended now for chlamydia. So, we've been using both azithromycin or doxycycline as kind of first-line agents for many years. And now for the first time in the new guidelines, doxycycline has become the only first-line recommended treatment for chlamydia, and this is in non-pregnant individuals. And so if we have some time, we can talk a little bit about the data, but I think that's the biggest change, is that now azithromycin has been moved to an alternate treatment for chlamydia in place of doxycycline as the first-line treatment. And that's based on efficacy, that there's data that shows that the doxycycline is more efficacious than azithromycin.
Can you talk a little bit about what is the current best treatment for pregnant women compared to non-pregnant women?
Yeah, thank you. So I kind of mentioned that doxycycline was in non-pregnant individuals. And the reason why it's not a first-line drug in women who are pregnant is because there is this potential risk that the neonate could have stained teeth from the doxycycline used by the mother during pregnancy. So azithromycin is still a very good antibiotic to treat chlamydia, and particularly in women. And so azithromycin 1 gram single dose therapy is still the first line treatment. So that's not changed from the previous guidelines, that azithromycin is still the first line drug for chlamydia treatment women. There is one alternate treatment for pregnant women, that's amoxicillin, and that's 500 milligrams given 3 times a day for 1 week. It's just that the limited data that's published suggests that azithromycin is better than amoxicillin. And azithromycin, of course, is a single dose treatment. So for pregnant women who may have issues with things like nausea and vomiting, it is going to probably be easier just to give them a single dose treatment versus 7 days of treatment.
Yeah, and what are some of the challenges, I guess, with compliance when it comes to the single dose versus the 7 days?
Yeah, I mean, this is one of the biggest struggles, I think, for people now changing kind of this first line therapy. Is we all know that sometimes people cannot adhere to a full 7-day course of doxycycline. So that's, 1 tablet twice a day for 7 days. That's 14 tablets. And so I think there's great concern that people won't adhere with all 14 tablets. But it turns out there's pretty good data showing that if you take at least about 10 of those 14 tablets, so at least about 5 days of treatment, that the cure rate is pretty much identical, that, essentially almost everybody is cured with doxycycline. There's even some more limited data to suggest that even less than 5 days will sometimes actually, of the doxycycline will still sometimes cure chlamydia. And there's actually one group of investigators I'm aware of who's interested in studying as short as only 3 days of doxycycline compared to 7 days. So I think the concern of adherence for doxycycline, and maybe it won't work for chlamydia, is probably overrated. I think most patients will take, some or most of the doxycycline and it's still going to work. And so azithromycin should probably be reserved for those who you really think may not even pick up the doxycycline or take more than just a few days. And of course, for pregnant individuals.
Oh yeah, definitely. Thanks so much for sharing all that. That's very exciting, seeing maybe some of the shortening of the treatment course. Can you talk a little bit about expedited partner treatment and what some of the challenges are associated with that?
Yeah, I know. I'm glad you brought that up because I think challenge is the word. And so, expedited partner therapy, if you're not familiar with this strategy, this is a strategy where basically a patient, a partner of a patient is given therapy in an expedited fashion by the provider directly without having to see the provider itself. And so the way this usually works is a provider gives a medication to a patient to give to the partner to get that partner treated. So the advantage of this approach is that you're going to get hopefully more partners treated, and that will limit transmission, back to the patient themselves or potentially other partners. And so we would like to do this approach, but as you can imagine now, I just said that the first line treatment is now just doxycycline. Before when we've done expedited partner therapy, we've always used azithromycin where you didn't have the safety concerns about maybe a female partner taking a medication and what if she's pregnant and could that affect her baby? And so, the new CC guidelines, honestly, they just don't really address this in the guidelines. It's kind of left up to the providers about how to approach this. And so, but I have talked to other providers out there, many who have studied this approach. They're still using azithromycin for expedited partner therapy. So even though if you are seeing a patient as a provider, you're going to use doxycycline because that's what's recommended by the CC guidelines. Right now, for the expedited treatment of partners, people are still using azithromycin for that because they want to be ensured that the partner is going to take it and they don't want to worry about a potential adverse effect in that partner by giving them doxycycline. So this is an area of controversy. Like it's just there's not great guidance about what to do, and people are still doing what they've always done for EPT, which is using azithromycin.
That's very interesting. And speaking of some of the challenges, what about what do the guidelines say about how long patients should abstain during or following treatment?
Yeah, that's challenging because some people don't want to abstain very long from having sex. Okay, but the thing about chlamydia is that it's a very slow growing bacteria. And so it definitely kind of takes time for you to kill it with the treatment. And so what the guidelines recommend, which is what I think is appropriate, is that you wait at least 7 days after beginning chlamydia treatment before a person can resume sex. So what that means is if you take 7 days of doxycycline, it would be the end after you finish the doxycycline. And if you take 1 gram of azithromycin, it would be 7 days after you take that 1 gram of azithromycin. But also the guidelines the guidelines recommend not resuming sex with a partner until that partner's also been treated. And so, not only does a patient have to wait 7 days after starting their own therapy, they really have to wait that 7 days until after their partner has also started their therapy if the person they're going to resume sex with is that actual partner. And so it's really important to wait that long. I wouldn't go any shorter because there is that risk that maybe there's some, still some chlamydia that are alive and that you can, get re-exposed if you don't wait that long.
Absolutely. Next, I want to change gears a little bit and talk about testing and what the guidelines say about testing. Specifically, can you talk a little bit about extragenital site testing?
Yeah, so when you say testing, let me first separate 2 areas. You have what we call screening versus what we call kind of diagnostic testing. And so screening is when you have individuals who are not having any kind of signs or symptoms of infection, and you simply recommend, that they get screened for infection. Versus diagnostic testing is when you have an individual that has signs or symptoms of infection, or maybe they're a contact of somebody that has an infection. And so you're doing a diagnostic test for them. So regarding screening asymptomatic individuals, what the guidelines recommend is that all sexually active women under the age of 25 get screened for chlamydia once a year. And those who are 25 years of age and older, that they get screened if they have any kind of risk factors for chlamydia, such as unprotected sex with a new partner, having multiple sexual partners, or having a partner who has other partners. That's the women. In the case of men, there is no kind of routine screening in men for chlamydia based on age, which I'm kind of disappointed by, actually, because I think there probably should be. But what the guidelines do say for men is that men who are in venues like clinic settings where they have a higher prevalence of chlamydia, like an STD clinic, for instance, that it's reasonable to screen men in those populations, or men themselves who have known risk factors for chlamydia should also be screened. Now that's routine kind of urogenital screening. You asked me about extragenital screening. So we're talking about screening at the oropharyngeal site and screening at the rectal site. So for men, first of all, for extragenital screening, men who receive anorectal sex, it is recommended that they be screened for chlamydia at least once a year, perhaps every 3 to 6 months if they're at higher risk. For women, in terms of anorectal screening, there is no kind of quote routine screening recommendations. But what is different in the current guidelines is from the previous guidelines is that now they do suggest that if a woman has exposure at the rectal site, that she have a discussion with her provider about whether that she should be screened or not. And the oropharyngeal site, excuse me, at the oropharyngeal site, there is no recommendation in men or women for routine screening. The reason why is because even in the very high risk men or women have oropharyngeal sex, it's very rare to isolate chlamydia there. Only about 1 to 2% of the time do you find chlamydia in very high risk individuals. So, you know, in both those populations, men and women, there's no routine oropharyngeal screening. Now, let's say you have a patient that's the only type of sex that they have. Then I think it makes complete sense to screen them at the oropharyngeal site. But if they're having sex at the rectal site or urogenital site, it really makes more sense just to screen them at those sites because it has such a higher yield. In terms of diagnostic testing, whether it's a male or a female, if they're having signs or symptoms of infection at an extragenital site, then you want to test them at that site.
Right. I mean, I think that makes a lot of sense. Another question I had, I was reading a little bit about auto-inoculation in women, specifically to the rectal side, and what is the significance of that?
Yeah, this is a really interesting point that you brought up. So there's this concept that even though some women may never have sex at the anorectal site, you can still find chlamydia there. And the way that it's getting there is because, you know, the chlamydia are getting inoculated into that site, primarily because there's such a close proximity between the, you know, the vaginal opening and the anal site that whether it's through secretions or just wiping or other means, chlamydia is actually getting into the anal area and then infecting that site. And so there's actually been 3 different meta-analyses published looking at, you know, women, looking at the difference in how often you find chlamydia like at the urogenital site versus at the rectal site. And in general, just to try to summarize across these 3 meta-analyses, what they find is that if you take women who you know have chlamydia detected at the urogenital site, you can find it at the rectal site in anywhere from about 30 to 80% of these women. And if you look at how often those women report having anal sex, there's really no association between them reporting anal sex and you finding chlamydia at the anal site. So I think the point is chlamydia finds its way sometimes in women to the anorectal site, even when they don't have sex there. And, you know, it's a very important concept because when we used to use azithromycin as our first line treatment, azithromycin is not a very good antibiotic for treating rectal chlamydia. Recent randomized controlled trials have shown cure rates with azithromycin for rectal chlamydia in the 70s percentile range. And so if we were treating a woman for urogenital chlamydia and we didn't know if there was chlamydia at the rectal site and we were using azithromycin, there's a great chance that, you know, you might not adequately treat rectal chlamydia. And then it could re-inoculate the urogenital site all over again. And, you know, that would put a woman at risk for complications such as PID and infertility. So I think just recognizing the fact that women can have auto-inoculation of the rectal site with chlamydia, and that whether we test for it or not there, we need to make sure the treatment that we use adequately covers them at that site. So that was a really important finding in recent years. And that has been mentioned in the current CDC guidelines about why, one of those many reasons why we've moved from azithromycin as a first line drug now to doxycycline, which doxycycline cures, you know, up to, you know, upper 90s percentile to close to 100% of chlamydial infections at the rectal site. So it's a much better treatment than azithromycin at that site.
That's very interesting. And what do you think, you know, we've talked a little bit about the rectal side. What about the oropharyngeal infection? What do you think is the significance of that?
Yeah, that's kind of $1 million question. You know, we don't really know the answer to that other than clinically, overwhelmingly, most people who have oropharyngeal chlamydia detected don't have any signs or symptoms of infection. And even the ones who have signs or symptoms, it's a very, very mild pharyngitis, one that you could not really distinguish from maybe like allergies or viral infections or just other common infections. And so, clinically, most people don't even know that they have it. And then, as I mentioned earlier, if you try to find it there using the best tests we have in the market right now, and the highest risk people, you're only going to find it 1 to 2% of the time. So testing for it, you're using a lot of resources to test for something you're rarely going to find. And for most people, it doesn't cause any signs or symptoms. However, there is one big caveat to this, which is that there's been a couple of studies that suggest that, even though it may be asymptomatic in a person, it is potentially still transmissible from the throat of that asymptomatic person to the genital tract of somebody that they, have oral sex with. And so we're kind of torn, should we really be testing everybody in the throat knowing that we'll rarely find it? But if we did, then perhaps we could, automatically go ahead and treat somebody who's been exposed through oral sex at that genital site. But, following the CDC guidelines, at this current time, because it's just so low yield, they do not recommend doing oropharyngeal testing. It's just that, beginning back to your question, we don't understand why is it it just doesn't thrive in the throat site, versus like the rectal and genital site, chlamydia can persist for weeks to months, and some people over a year. We don't believe that happens at the pharyngeal site. So either it's not transmitted as efficiently, or maybe our immune system clears it quicker, or there's other factors we don't understand, maybe about the local flora in the throat that affects its survival. But, I would love to do more research in that area if somebody would give me money to study that. But, we just simply don't know enough about it. So we're taking a very conservative approach and just not testing most people for it because it's just not a good use of resources.
Absolutely. And speaking about research, I was wanting to know, what do you think is kind of the important future directions for future research?
Yeah, I'm always, thrilled to talk about research. This is something I'm very excited about. And I could talk all day about this, but I will limit this to maybe a couple of things that I think are really critical, but also clinically practical. So one is we don't have a point of care test for chlamydia right now. Point of care test is a test that if you come into a clinical setting, you could test somebody and then, know whether they have a positive test within a matter of minutes. So right now for a chlamydia test, we collect specimens, we have to send them to a lab where it takes hours to perform a test. And then most patients don't get the results back into, at least a few days later. And because of that, we end up over-treating a lot of people for chlamydia who actually don't have chlamydia. And we end up counseling a lot of people that they may have chlamydia. We cause a lot of fear, anxiety, depression, and other symptoms by telling them they may have chlamydia when we could have a rapid test to tell them pretty quickly whether they do or not. And so we've not had a commercially available chlamydia point of care test to date that was as good as our routine tests that we do for chlamydia. But fortunately, there are some in development right now that are within maybe a year or two away. And so I'm really excited about the possibility that we're going to have a point of care test for chlamydia that will drastically change our approach to the diagnosis and management of chlamydia. So I think that's one area of research that we're trying to get advanced into clinical practice that will make a huge impact. The other area, and this is one that's really close for me in the research that I do, is chlamydia vaccine. So, most industrialized countries like the US, we have a national chlamydial screening program where, again, we do chlamydial screening in certain populations. But data has shown us year in and year out that our chlamydia rates are not going down, they're going up. Every year, what we're seeing is that usually the highest chlamydia rates that we've ever seen before. So we have a screening program, and maybe it's helping to decrease some of the PID and infertility, but it's not cutting back the number of chlamydial infections. And so I truly believe that if we're ever going to really control chlamydia, we need a vaccine. And so there's a few groups, including our group, that are studying chlamydia vaccine candidates right now. We're at really, really early stages. There's actually has been one chlamydia vaccine that's already gone through a phase 1 clinical trial that's been published. And so there's a lot of excitement about this. And if I think, maybe in the next 5 to 10 years, if we could move a chlamydial vaccine to market and make it available worldwide, I think we could have a huge impact on chlamydial prevention like we've never seen before. So to me, I think those are two of the most important areas of research that will lead to a clinical application that will change our practice, and that's the point of care test and a chlamydia vaccine.
That's very exciting. Thank you so much for sharing all of that. I think you've answered most of my questions. Do you have any closing thoughts or anything else you feel like is important for us to touch on?
Yeah, maybe if we're okay on time, I can just bring up a couple of things that I see a lot that I think people don't realize are quite important. We all know that whenever men have chlamydia of the urethral site, they get painful urination and discharge, and it's fairly obvious to a lot of providers that they have, potential STI at that site. But in my experience, a lot of providers don't realize that women can also get urethral infection, okay? And clinically, it can look just like a urinary tract infection where they get painful urination. You take a urine sample from a woman, you do a urine dipstick, it shows white cells or leukocyte esterase positive. And a lot of providers just see these women, they diagnose them empirically as a UTI, and they give them Bactrim or Cipro to treat them, and they send them out the door, and they don't do a sexual history, they don't test them for STIs. And it's really a huge missed opportunity for diagnosing chlamydia or some other STIs like gonorrhea and trich that also cause similar symptoms. And so it's a great chance for me just to mention that anytime you see a young sexually active woman with UTI symptoms, please take a sexual history from them. Consider testing them for STIs as part of that workup for their symptoms. I want to say also that, PrEP in the HIV world has been a huge advance for preventing HIV infection. I think it's wonderful. But one of the consequences sometimes we see with PrEP is that sometimes those who take PrEP maybe don't use barrier precautions. We're starting to see, an increase in STIs. And so I wanted to just kind of leave the message that, STI education is very important as a component of PrEP because some STIs also facilitate transmission of HIV themselves. And so I think that's another area I'm starting to see that I feel like needs a little bit more attention. And then the last thing I'll mention is pregnant women. We didn't talk too much about pregnant women with chlamydia, but they are a group that has also unique risk when they get chlamydia. So they can have a miscarriage or a stillbirth or a premature delivery. And when a baby passes through the birth canal, the baby can get infected with the mother's secretions in their eyes or in their lungs. And so chlamydia is a very important infection to diagnose in pregnancy. And any woman, younger woman per the CDC guidance, younger than 25 or at increased risk for chlamydia at any age, really should get screened at their first prenatal visit for chlamydia and should get screened again at their third trimester. And it's very important that that's done and that their partners are also treated. So I just want to, send that out there too, because I think my experience sometimes that's missed. And that's another very important area of, care in, for those who may have chlamydia.
Dr. Geisler, I actually had a couple questions that came to my mind while you guys were talking. One question is that, do you know if chlamydia can be transmitted like on fomites, like sex toys or hand to finger kind of stuff? Can you comment on that?
Yeah, that's a very good question. It's one that I can't say we have a lot of data for, but we do know that, chlamydia is in a couple of different biological forms, and one's called an elementary body. And it's one that can survive in chlamydial secretions probably for a few days before the organism dies. And so I think if there's ever direct exposure to body secretions that have chlamydia in them through non-sexual routes, such as sharing a sex toy, then yes, I do think there's a possibility that you could transmit chlamydia. On the other hand, environmental surfaces like toilet seats, money, and these types of things, which you're in contact with maybe just the skin, intact skin on your hands or, legs or arms, et cetera. I think that the likelihood of transmission of chlamydia is so low that I wouldn't be concerned about it. So if it involves secretions from a mucosal site and you're exposed in mucosal site, then yes, I think there is a risk through non-sexual routes. But fomites, I don't think there's much risk otherwise for transmitting through just fomites.
And one other question, we talked about expedited partner therapy, and I know we all, that CDC map kind of evolves as the states, more and more states are allowing EPT. And unfortunately, Alabama is kind of still one that's permissible. There's a few states potentially allowable. There's still a few states, including the one that we live in, that are not green. Do you have any advice for providers in those states on how to manage partner, services?
Yeah, that's really tough. So CDC has this really excellent site. If you go to CDC's website and you search for EPT, it'll bring you to this map that Dr. Muzzey's referring about the different U.S. states for which EPT is either allowable, potentially allowable, or maybe not permissive. And so there's a few states still where it may only be potentially allowable or not allowable. And so I think if you're in a state where there's any uncertainty, the first thing I'll do is go to the CDC's website. If you just click on the link for your actual state, there's a lot of information to tell you what we've learned for your given state about whether it's permissible or not permissible and why. I think otherwise, if you have questions, your local health department is a really a good source, because your local health department is going to be in contact with your state health department, who should be in contact with CDC. And so whether it's permissible for you in a given state, if you're unsure, I think I would encourage you to go through your health department, because ultimately they're the ones that are in contact with CDC. You can obviously ask if you have local STD experts in your area. Most of you out in the US are going to have a training center that's going to support your area that you might be able to reach out to them. But I think if you have uncertainties, I would recommend that you reach out to the health department to ask for guidance on that.
And finally, my last question, do you want to say anything about BV and chlamydia co-infection?
Well, sure. BV and chlamydia, I love talking about those two together. Though we don't have a lot of time, I know, so I'll try to limit it. So if you're not aware of what bacterial vaginosis is, this is a vaginal infection, one of the most common vaginal infections in women, where their normal bacterial flora, which has hydrogen peroxide producing lactobacilli, gets replaced by other bacteria like Gardnerella and anaerobic bacteria. And it leads to symptoms such as a vaginal odor and discharge, which brings many, many women to their providers to seek care for that. There's been really interesting data come out in the last 10 to 15 years to show that there's a very strong association of this bacterial vaginosis with chlamydia, with getting chlamydia or getting recurrent chlamydia. And there's been some really cool research, in vitro research, that suggests that what may be going on is that some of the bacteria that cause bacterial vaginosis produce metabolites such as indole, that chlamydia have an enzyme that they can actually take the indole to make metabolites that chlamydia needs to survive. And so here you have the host immune response making interferon gamma, trying to kill the chlamydia. Chlamydia is trying to fight this by taking indole from bacteria and making their own tryptophan. That's how chlamydia is killed by the host, mainly is that it depletes the host tryptophan. And so it's this really cool interaction. It's just an example of how you have synergy sometimes between an STI and one's own bacterial flora. And this is an area that Dr. Muzzey and I are both investigating together kind of in the future. And she has a lot of other collaborators as well, that we think that, there could be changes in who we recommend to test or how often to test, depending upon whether you may have certain types of bacteria in the vaginal or in men, perhaps, maybe even the men's urogenital tract area. So a really exciting area of chlamydia and bacterial vaginosis research that you'll probably be seeing a lot of papers in the next decade or so coming out on this.
All right, well, on behalf of ITSOG, I really appreciate you guys for being here today for our Ask the Expert series, and we appreciate it and everything you do for sexual health. So thank you guys so much.
Yes, thank you for having me today.
Thank you.
Thank you.
All right.